Hello, hello. Great to see everyone. I am so excited to have y'all join. We're going to start with some announcements before we jump in and do introductions today and talk a little bit about our guest and what we're going to do. So as always, a couple of announcements. Number one, thank you for joining this live stream. Our live streams are not intended to replace therapy, but are really intended to be educational, supportive, and I hope informative in different ways. And so what that means is that if you're asking specific questions for your own treatment or therapy, we really want you working with your individual providers. And of course, if you're in crisis or distress, please, now you can call 988 if you're here in the United States, which has become our suicide prevention hotline and emergency line across the country. But of course, if you're international, please follow your emergency resources. IOCDF and or our live streams are not intended to be the place to go if you're having a safety crisis or in distress. Of course, as always, there are some incredible announcements. So as you guys know, you can visit iocdf.org/peace of mind to learn more about all of our upcoming live streams, what we have going on, and of course, to also submit questions. So this is a great place that if you don't have time to submit your question live or we don't get to it, you can post it here so that we can hopefully answer it either in advance or during our next live event. And of course, next Tuesday is one of our research. Sorry, I'm wrong about that. As always, here I am. This is where we get to have fun and be vulnerable together and I make mistakes. So next Tuesday, not next Wednesday. So next Tuesday evening at 7 p.m. Eastern time, you can join Dr. Bramowitz, Ethan Smith, Dr. Reed Wilson, and Brittany Goff for September's town hall. This town hall is going to be on metacognitive therapy and ICBT, and it's part 2 to a recent town hall that we just had. I know I'm going to join. I'm really excited to learn more. This is an opportunity for us as we've been talking in the field, and we might get to some of this today about new interventions, what we might kind of call adjunctive treatment. So treatment you might use in combination, in addition, after, before ERP. And it's really important for us that are in the field, whether we're individuals or clinicians, to be thinking about when are the times that ERP alone may not be the only intervention that's what's best for that individual. When do we need to consider other interventions? Or as patients, when should we be considering other things? And so I want you guys to use this platform as an opportunity to learn as much as possible about interventions, treatments, what it looks like to then better make decisions for yourself and your own care, or if you're a clinician, to make best decisions for your patients in their own care. And then, of course, our upcoming conference. So we will have the TOC, which is our Spanish OCD conference, in just 2 weeks. We are so excited that it is going to be here before you know it, but there is still time to register. So please be sure to follow the links below. So I am so excited. Y'all might be wondering, where's Chris and why is Callie here? They don't look the same, so that's for sure. But I am so excited to have our guest. So Callie Werner, many of you may already know. Callie is, like Chris, an amazing advocate and an amazing clinician. Callie and I have worked together for many years, and I love the work that she does. I want to let her spend a little bit of time introducing her passion, her interest, why she got involved in OCD work. But I can promise you that while we are, of course, sad Chris isn't here, he's on a much needed vacation. I know you guys are going to be excited and honored, and Callie will blow you away because I am personally excited and honored that she's here and always am. So Callie, so great for you to join us. Tell us a little bit about yourself, why you love this work, and why you do what you do.
Thanks, Liz. Yeah, I'm really excited to be here. This is my first time on Ask the Experts. So really looking forward to answering some good questions. But just a little bit about me. I struggled with OCD most of my life. Since I was about 4, my parents noticed some symptoms, but wasn't diagnosed until I was 21. And so there were, as all of you know, lots of hardships along the way with navigating through that. And once I got treatment, it was life-changing, and decided to change my career path from what I originally wanted to be, which was a sports reporter, to an ERP clinician. And so that is where I am today. And I competed in college as a Division I athlete and was a distance runner. And so I'm still running now, trying to run for my second Olympic trials, hopefully. And so I'm really passionate about how OCD shows up in sport and ways that we can be preventative, because we know that the symptoms of OCD only tend to make our sports performance worse if they are not treated correctly. So that's a little sneak peek.
Well, we are excited to have you and excited to hear your background and expertise and the way you integrate that in. The thing I'll say about Callie, she's very very humble, but she is an absolutely incredible clinician and advocate across the board and helps so many people. And I am so confident that she's going to have that same impact both today and on future live streams. So thank you for being here, Callie. Let's hop in. So I'm going to start, you guys, as we always do, with some pre-submitted questions. If you see me looking all over the place, that's why. And then, of course, we will answer questions that come up live. So please continue to post your questions in the comment pane that you see on the right-hand side of your screen. Let us know anything you want us to answer, and we will do our best to address those. First question I want to ask, Callie, is somebody submitted a question saying, I'm looking for a new job, but I cannot take a job where there is somehow a trigger word that is associated with death or diseases. I think if I take the job, I'll die or get sick. What should I do?
Great question. So I think we have all heard on this platform at some point that we should not let OCD dictate our life decisions and choices. And so we have to start small sometimes, because if we do that hardest exposure and jump into that job where we know we are going to be absolutely triggered, it might scare us away. But I think if you are passionate about a specific job or you want to do a certain job, you should work on that exposure response prevention to get you there. And that's starting small, a little bit of exposure work at a time. Maybe, by, well, first off, finding a clinician to help you do that. But then maybe they can help set up a plan for you to expose to some of those trigger words without being at the job at first, and then eventually getting to that place where you do feel comfortable. I think it's important to note that the first time you go on that first day, it's not going to feel really comfortable, right? Just like any new exposure would be, it's going to feel a little bit scary at first, but white knuckling it and avoiding life only gives OCD more control. And so making sure that you're putting your values ahead of the OCD compulsions and working in small steps a little bit at a time. And I don't know, Liz, if there's anything you want to add.
I think that's perfect. Exactly what I would say. And, I think the big piece that Callie's really trying to emphasize that I want to say is that our goal is that OCD doesn't make decisions for any piece of our life, whether it's work, friendships, relationships, hobbies, you name it. And so what I actually want you to do is turn this into motivation, right? Which is that I want to take a job that is going to somehow be affiliated with death or disease. Because what we know is that while you may not, even if you're like, I don't want to be a nurse, I don't want to work at a hospital. Okay, that's fine. I'm not saying you have to go to nursing school just because, right? But what we know is that if we take jobs where we can try to avoid death or disease, that's actually not avoidable. So it's going to come up anyways. It's not like if you take a job you're not interested in, you'll be able to avoid this fear, right? The fear will come up in different ways in our life. And so we just want to make sure OCD isn't making decisions for us. Remember, avoidance plays just as big of a role in the OCD cycle as compulsions do. And in fact, I would actually say avoidance oftentimes plays a bigger role, because it stops us and makes us not only do we not get to do the things we want to do, but it also makes us believe we're not capable of it. Where if we do some rituals, we can address the rituals because they're frustrating, but at least we're still doing those things that are important. Next question. There is a question specifically around BDD, and so I'm going to save that both for Chris and future live streams where we can focus on. But let's just jump into some general ones. There's a question that says, any advice for someone who has difficulty with ERP?
Want me to go?
Yeah, please.
Perfect. So with ERP, I think kind of looking at it, we all sort of have difficulty with it, right? Like when we jump into doing an exposure, it's scary and it's uncomfortable, and it's probably in that moment the last thing that we want to do. But kind of to piggyback off of what Liz just said, our motivators are a really big driver to help us do those difficult exposures. And we have to remember what the big picture is. So if your OCD is keeping you from something that you love, because oftentimes we know that OCD does attack our values, then we should be kind of putting our eye on that prize and then doing those smaller exposures to help get you towards that a little bit at a time. But I think great story is just remembering that when we're struggling or we're like too afraid to start ERP, start with the education, right? The education behind what ERP is, what acceptance and commitment is, and recognize that it's either, okay, I continue down this path of not challenging OCD and continue to struggle and white knuckle it, or I face kind of similar discomfort. I always say when we're doing exposure work versus doing a compulsion, usually both of the times we're feeling discomfort. So we would want to feel the discomfort that gets us closer to that life we want to live, right? So kind of weighing out those pros and cons usually will always get you back to wanting to do ERP. And I think reminding yourself, it's a lot easier to do our ERP when you have a provider walking through it with you. So having that extra accountability, because doing it on your own can feel isolating at times, especially if you're just starting off.
100%. Love that. Next question is, why do I need to keep track of everything in my life? Why do I feel the need? And I'll just answer that quickly. And, I think that this is a hard one because I obviously don't know the details. But what I will say is that oftentimes this urge to kind of track and understand everything, it's almost this sense of control, right? Can I have control over what's happening? Can I know everything that's happening? And what I'm going to push is, not only is it not possible for us to track or have control over everything in our life, but it also takes us away from being able to live in that moment, right? When we think about anxiety in general, if we're not even talking about OCD, anxiety doesn't live in the present. It lives in the past and it lives in the future. And so our goal is to get us back to the present. So while we might have that urge, I want you to think about what choice you're making, right? Do I want to cross into the past, go back into the past or cross into the future? Or instead, do I want to stay in the here and now and be able to experience joy, experience being present, experience those things that are really valuable in life? The next question, Callie, I'm going to throw for you is, hi, I've been struggling with OCD since I can remember. I had a lot of themes over the years, but false memory OCD is something I can't deal with. How can you live with uncertainty without feeling isolated from the rest of the world? It feels like I'm living in denial and possibly hiding a huge secret from people around me.
I love this question so much, mainly because it hits really close to home, and very, very relatable. And so first off, I just want to tell you, this is something vulnerable moment that I have struggled with, and you are not alone. So you are not the only person that has struggled with this need to hide this big secret, and has been, I think another big thing with false memory OCD is you can be latched onto it for a really long time, right? Like it can be days or even years that you go back to this thought and it brings you a lot of anxiety. And so just hearing that you're not the only one going through that, I hope that makes you feel a little bit less isolated. But two, when it comes to all uncertainty, including false memory OCD, we are choosing to make a commitment to living today, regardless of what that fear is, right? And so if we concentrate on whatever the thing is that we fear that we did, or we fear that happened, it is going to take us away from living in that present moment and only make that thought or that fear stick around longer. So the goal is to be engaged in your life in that day, even though that fear is buzzing around behind you, or that false memory is buzzing around behind you. And it's so terrifying, right? Because there's this thing in the back of your head that says, am I going to be latched onto this forever? But the reality is, if you keep moving forward one day at a time, that fear, even though it might not be gone, it gets smaller and smaller and more manageable. So just taking it that way without focusing on the kind of like putting the extra pressure on yourself to make sure that I have to get rid of this thought, only actually makes that thought stay longer, right? Like, don't think of a pink elephant. So trying to just move forward despite the thought being there is what's going to give you the most freedom long term.
So what happens, I want to play the flip side because I get this question a lot, is, what happens when it feels so real that we're saying like, well, it must not be OCD, or like, this can't be OCD because actually feels real. And like the other ones felt more irrational, or the other things that stuck, I knew there was a little bit like, right. It's kind of this real event where sometimes things are rooted in something that actually did happen, or there is this reality that could be there. And I just don't know how to shake it. If it feels different, if it feels real, how can I still just treat it as OCD? What would you say?
I would say, and you add to this, but I would say, like, when we have an anxiety disorder, a lot of our feelings are a little bit out of whack in the moment, right? Especially when we're triggered. And so if we are relying on our feelings, that's only going to make us avoid more. That's only going to make us focus on the OCD thought more, or the fear more. And so kind of in that moment, we have to say, okay, I'm going to put the feeling almost to the side right now, because we always say the thought comes first and then the feeling follows. And so, or the action comes first and then the feeling follows. So the action would be trying to engage in your day, trying to do the exposure work of being present. And then maybe, the feeling later will start to feel a little bit better, less anxiety provoking. But I think that's a really good point too, is sometimes really scary things do happen, right? But we know that, like we say, we can't live in the 1%, but is still a 1% and there's a 99%. But if we stay with that 1% and wait for that 1% to happen again, which, may or may not, we're missing out on the 99%, which is where there's so much joy, happiness, and freedom.
Yeah. And what I'm going to push is that, my push to everyone is, how do you okay, so let's pretend that we are stuck and it feels like it's not OCD. And so we need to solve it. Like, how's that working for you? Mm-hmm. Right. And what I mean by that is that these things aren't solvable anyway. So the reality is like OCD wants us to know for sure, right? About anything. It's no different than a contamination exposure where it wants us to know for sure that we're safe or something bad isn't going to happen or there's not going to be this negative outcome. And we're trying to teach you to actually be able to make the best decisions we can in life and move forward and accept that there's probability and uncertainty in everything we do. This is no different. And what we know is that the more you try to solve, the more you're going to get stuck. Solving gets us stuck. Compulsions make us more confused, right? So remember, compulsions equal confusion, solving equals stuck, right? No matter how much you try to figure it out, solve it, you're not going to have more freedom. You're not going to feel or have more clarity. You actually, though, will get freedom and you will get clarity if we accept thoughts. We don't have to accept them as being truth, but we just accept that the thought is there, that we can't get rid of it. And we try to just move forward despite that thought being there, despite it maybe being loud. We try to not make it quiet, make it go away. That's when we'll actually not just get more freedom, but we'll get more clarity. So these real events, if we actually kind of don't try to solve them and we do active ERP, we will actually end up having more clarity around them later. But you will have less clarity the more you do rituals because you get more and more stuck in them, more confused and more pulled in by OCD. Next question is, what should you do if the thing your OCD is currently centered around has in fact happened once, twice, or even 3 times? So even if you face the fear and you don't avoid it, it's literally likely to happen again, like a fungal infection in your fingernails. What would be the right way to answer this?
I think we see a lot of that even with COVID right now too, right? Like, telling, especially when it first came about, like telling us to wash our hands and do all of these things extra, especially for somebody with contamination OCD. That's a very tricky area to navigate. So if we take, fungal infection kind of in that same route, is it getting to a place where it is negatively impacting your life by trying to prevent it? And if that's the case, then we are not living in freedom. We're kind of living as a prisoner to that disease or whatever it is. And so trying to give yourself more into that uncertainty, even though you're right, it might happen again and you might have to treat it again. But if it is taking away from your ability to be present or do the things that you value, then OCD is winning.
Yeah, 100%. And the thing I want to say again is, not just what would doctors or medical professionals say, because that's really critical. But again, remember, OCD doesn't help us in reality. So what I mean by that is that if, for example, trying to give an example, my daughter last week had the stomach bug, right? She has a stomach bug. She's a little bit older. I have an infant, a newborn who I didn't want her to get the stomach bug, right? So I am going to keep them separate at least for 24 hours or until the bug is passed because I don't want the newborn to get it. And we can all agree that oh yeah, that makes sense. That's fine. But if OCD latches on, not only am I keeping them separate, I'm probably going to be doing all of these rituals. I'm going to be, really worried about cross-contamination. It's probably going to last way past the contagious period. I'm going to be, super anxious about what everyone touches, what everyone does. And what I might ask is, did the OCD behaviors create any more safety for my newborn? Did they keep her any more safe than the original behaviors that might have been recommended by the doctor? And the answer would be no. And so what we want to push is that there's a big difference in us following normal routines, rituals that are healthy compared to OCD rituals or routines. And so, it's okay to ask physicians or doctors okay, so what makes sense and how can I try to prevent this in the future? But what we know is that going above and beyond actually doesn't allow us, if this makes sense, but going above and beyond doesn't create any more chance that you're going to not have another fungal infection, right? Especially if you're predisposed to it and you know that it's something that's more common or frequent for you. And so again, it's like us recognizing that OCD doesn't actually serve healthy purposes. OCD just makes us feel like we have to follow these rituals and routines to try to prevent stuff. And actually what you're finding is a perfect example, because it's like, yeah, even if you do all this OCD stuff, you might still be susceptible and you might still get this fungal disease. And so we just have to approach it and address it when it comes up, because some wound contamination exposures or rituals can do a million rituals yet still get the flu, right? It's not a foolproof system either. So important to remember that. Let's hop into some live questions. So Skyla, thank you for all your work on the back end and pulling these up as they come up. We are going to start with, I would say 11:04, but it's 12:04 your time with, the question is, I have mental filtering type of cognitive distortion. I ruminate on safety-related obsessions. It takes months to neutralize them. Please tell me how to overcome this thinking error.
Mental filtering, cognitive distortions. So when we struggle with cognitive distortions, we want to reframe those negative thoughts, right? So if you're having a thought that I am a failure, okay, well, what is the evidence for and against that? And usually there's a lot of evidence against, because we tend to focus on the negative. So, if you've made one F in a class that you're taking, and you're telling yourself that you're a failure, well, how many 100s, 90s, and 80s have you made? Probably quite a few. And so we can't let that one thought filter out. So kind of just calling it out and labeling it for what it is as a distorted thought is really important in those moments. But when it comes to OCD, we do not want to find the evidence for and evidence against, because that is exactly what you put in the question, which is rumination. And so with OCD, we are trying to lean into that uncertainty of I want to just piggyback again off of what Liz was saying with the fungal infection, right? Like the safety mechanisms, there are safety protocols in place, but OCD takes that to another extreme that at the end of the day is probably doing more harm than good, right? Like if you are stuck in your head trying to figure out if you're driving correctly and doing all of these other things, that's actually probably making you less alert behind the wheel. And so trying to challenge those uncertainty pieces and bringing yourself back to the present would get you in a lot better place long-term.
100%, right? And remember, right, if in fact the cognitive distortion is related to, say, PTSD or related to something else, then we are going to treat it differently. But as Callie's saying, rumination is going to get us more stuck. And so if we're talking about this thinking error really being OCD related, it's really not about us kind of talking our way out of it or thinking our way out of it. That isn't going to get us to have freedom from it. And if you're finding that it's taking months to neutralize it, the urge to neutralize is typically OCD, right? And so remember, our goal actually isn't that we neutralize it. It's not that we get rid of the thoughts if it's OCD related. It's that we just allow it to be there and we move forward. And so we shouldn't be spending all this time trying to solve it or neutralize it. And if we do, that's exactly what will happen, is it takes a really long time before we get any level of freedom. But if we try to not neutralize in the moment, the freedom comes a lot quicker. I'll give you all a personal example, but I had a sexual intrusive thought this week, and it might have been last night or the night before, I can't even remember. But immediately when I had the intrusive thought, right, it kind of pulls at me, and I have this urge to like scan my body and see if I'm having bodily sensations, to kind of understand where it's coming from, to try to solve it, to make sure it doesn't mean anything. And all of these kind of OCD urges that want to pull me in, right? And if I wanted to try to neutralize the thought, to feel better about that thought, or to try to know it didn't have significance, I would go down that path. And it might take weeks, it might take months, who knows, before I feel like, oh, I feel this relief from that thought, or the thought has gone away. But instead, what I do is I don't try to solve any of it or figure it out. And I acknowledge that, like, oh, like that's a crappy thought I don't want to have, or like, wow, like there's that thought, that sucks. And I'm still going to get dressed and go to work for the day, right? So I allow the thought to be there, but I don't respond to it by trying to neutralize it, because that's where I'll get more stuck. And I choose to still live my life. That is ERP, you guys. Like, I think a lot of times we think ERP is like, I have to sit and do this long script and I have to go through all these worst case scenarios. But ERP is often about choosing to live our life and not suppress the fear or not solve the fear. If, however, when I had the thought, if I chose not to ruminate or like, go into solving it, but I was like, oh my gosh, I can't have that thought. I need to hurry up and get dressed and get showered and get to work. And I still was responding with like urgency of suppressing the thought would have kept following me throughout the day, and it would have kept popping up, and people would say, well, I didn't ritualize, but it's still there. That's white knuckling, right? That's when we are trying to like make it through and survive the day and still live our life, but we're trying to make sure we don't have to deal with this OCD. The way we approach it, right? ERP is about accepting the thought, accepting that the thought is there, right? I'm accepting the thought. Doesn't mean I'm accepting the thought as true. Doesn't mean I'm accepting it as false and trying to figure that out one way or the other, but I'm letting it be there. I'm not responding with urgency, and I'm moving forward, right? The way I respond of like this anxious response really impacts the power that it will have on my life. At 12:06, Ryan said, hi, I've been doing great in therapy and I've been using CBT. I feel like I'm plateauing, which can be quite difficult. I've had ketamine suggested to me as a way to help with this, and I'm back and forth about how I feel. Do either of you have knowledge on whether ketamine can actually help? So I'll kind of answer the ketamine part, and then Callie, I'll let you talk a little bit about plateauing and treatment. So what I want to say, Ryan, is we really don't want to answer medical questions since we're not, neither of us are psychiatrists. But I would really follow the suggestion of your provider. I don't know that ketamine is an evidence-based intervention for OCD, but ketamine certainly can be useful, and people use it for depression and other things. And so I think this is really where you have to work with your providers, both hopefully your psychiatrist and your clinician, your OCD behavioral health clinician, to really say like, what might make sense? And is this something I should consider to help amplify my treatment in different ways? So this is kind of a personal thing. I don't think either of us can say, yes, it can help, or yes, it won't help, because it's really what is recommended for you in your course of treatment. But Callie, talk a little bit about what it's like when we plateau in treatment and how we can address that.
Yeah, I think plateauing looks a little bit different for everybody. So for me now, at my current state with my OCD, when I plateau is when something triggers me and then I jump into work or other things that keep me busy and focused on that, so that I don't have to deal with the obsession until it gets in the way too much. And then I get to this full blown state of panic. But sometimes we plateau when we hit these exposures that we do really well at, and then we're not able to take that next step on that next more difficult exposure. And we just kind of get stuck, or we push it to the corner as much as we can. And it makes it doable maybe for a little while, just like a compulsion would, right? Like we can live in that plateaued state. But I think when we remind ourselves of what our end goal was, why did we sign up to do ERP? Why did we sign up to challenge the OCD? Well, it's because we want more in life. There's goals that we don't want our OCD to slow us down from. And accountability. I think accountability is one of the biggest things that I would encourage. If I were struggling with kind of jumping into work and distracting myself from doing my own OCD work, and I was only seeing my provider at that point once a month, for sure, I would wait until that very last moment before I see my provider to make sure that I do my ERP homework. But at the end of the day, is that helpful? Because, if we're doing, I always use the analogy of like, if you have a terrible fear of flying and you're only flying once a year versus maybe you have to fly for some reason, you have to fly once every 3 or 4 days, you're going to get over that fear of flying a lot quicker than you would if you were to only fly once a year. So if I'm waiting until that very last moment to do my ERP exposures, it's not really benefiting me in the way that I need for it to. And so having someone check in with you and just saying, hey, how's it going? Like, I know we set this goal for you to do for your OCD work. Were you able to do it this week? And keeping that consistency, but also just remembering, and I know I've said this many times already, the big picture. Like, what is it that your OCD took away from you that you're working for to get back, and have that posted somewhere, right? Like for me, when I was at my worst, I had like a vision board of my wedding on Pinterest. And I always call that a bittersweet exposure, because it was very triggering, because I thought, wow, there's no way that I could be in a relationship with how my OCD is right now, but that's something that I value and want in my life. And so it was fun at the same time to be able to pick wedding cakes or like do all those things and put it on my Pinterest. And so somewhere where you can have those reminders can really help you with that plateau.
Definitely. 11:07 or 12:07 your time, Skyla, from Jabber. I suffer from severe checking OCD. Any advice on how to deal with feeling inferior at work due to OCD slowing me down?
So I would say with these types of exposures, are there certain things that you are doing kind of like as a barrier? I think checking OCD can become more complicated now with technology too. So like asking yourself, what are all of the checking behaviors that you're doing? Am I, taking pictures of my lock with my phone? Am I going back many times? And set a small goal. Try to get kind of like a baseline for how much you're doing. Am I, checking 10, 15 times before I go to work, and then asking yourself to just start to limit that if you can. But then also, setting this standard in your mind that it is going to feel uncomfortable when you go to work, right? Like if you're doing the exposure correctly, it's going to be hard, and your brain is going to want to take you to that worst case scenario. But something Liz and I have been talking a lot about lately is accepting the worst case scenario, like the fact that your house burned down, is also accepting certainty, right? So going to that worst case scenario of this is definitely happening is not living in the uncertainty. So we have to go back in I don't have full control over this situation, but right now I need to get to work, and staying in that middle ground. So best case scenario of, I know that I checked my door. I have a picture of on my phone that shows that it's locked. That's a full-on compulsion. That's living in the 0% risk. The full-on worst case scenario is living in the 100% my house definitely burned down. Neither of those are helpful. So make sure that you're in that middle zone.
Yeah. And the piece I want to push is that as far as shame and stigma goes in the workplace, when we're dealing with OCD, to really give yourself grace and to think about what would you tell somebody else that you cared a lot about, who was struggling with anything, right? If someone's going through a divorce, if someone's going through life changes, if someone's going through even a move, right? You might give them more of a break that week on their work and their product, and do the same for yourself. At the same time, I also don't want us to use OCD and to say like, oh, we're never going to be able to produce at the level we should because of our OCD, because now we're actually just giving OCD a chance to live and thrive and be big. And so as Callie's been mentioning, we want to think about what's our greater good and what's our goal, and use that as what we're fighting towards, but also give ourselves grace in the process to get there, right? We don't expect that we're going to overnight not have OCD interfering with work, but I also don't want anyone on here to accept that our OCD should make us not as good at our job as we could be. Mike, you asked a question. How do you treat OCD and ASD? There's been some incredible webinars on it. So I recommend going to youtube.com and going to IOCDF's YouTube page. You can watch one of our previous OCD and ASD webinars to learn more about how treatment might look different when we're treating both. I am going to answer Leanne's question. They're 2 in 1. So I understand that I have to track certain behaviors, like number of times I wash my hands in a day, for example. But I'm stumped at how to track, how to write down the number of times I journal. How do I track behaviors without adding to the rituals? I want to make sure OCD is not making decisions for us. This is a great question, Leanne. And what I would want to push is the journaling OCD? If the journaling is an OCD ritual, you may want to track it in a way that like, it's kind of like, okay, I'm keeping track so that I can know what my goals need to be, right? If we don't know how much someone is hand washing, if someone's hand washing 100 times a day, I'm not going to set an exposure goal of limiting it to 5 times a day, because that might not be reasonable. But if you're washing 7 times a day, 5 might be reasonable. And so tracking is really important for us to then be able to set specific ERP goals. However, it can turn into a ritual. So tracking can become something where we become really ritualistic about it, and that isn't helpful either. So I would want you to think of it much more as like a flexible tracking, right? So can I just kind of understand? Can I just kind of think about this and understand what it looks like for me? If journaling is not an OCD behavior, oh, sorry, I think I'm reading this wrong. I think I'm reading now that you're using the journal, like you're saying you're using the journal to track the rituals, and how can it not become a ritual? So again, try not to be rigid about it. I would encourage you, actually, if you find that like it's feeling ritualistic, to purposely not track at least a couple times a day, right? Because now it's an exposure in and of itself. So it's about how can we not be rigid and how can we be flexible? Next question, Callie, at 12:11. To deal with severe checking, how do I decide what kind of a clinician I should look for? A therapist versus psychologist? The number of options out there is overwhelming.
Yeah, I would agree. The number of options out there is overwhelming, but I wouldn't focus as much on the license as I would the experience. So, like there's LCSWs, there's LPCs, there's psychologists, PhDs, all of those things can definitely be overwhelming, but do they have the background in exposure with response prevention, cognitive behavioral therapy together? That's a really important key. Like the list of IOCDF providers on the website, they all have that background. And so I would focus more on that, because there are kind of a secondhand, I think we think, oh, well, I definitely, sometimes even I thought this, definitely need a PhD because they have the most knowledge and experience, when that's not actually, always the case. It's really who has the most experience in that area of expertise. So looking more, or even going to your clinician or going to a clinician and asking specifically, do you have training in ERP? I think we're afraid to do that because we don't want to ruffle any feathers, but it's really important that they do, in order to help you the best that they can. And if they say, no, but like I know how to do, I know what an exposure is, I don't think that would be something I would hope you would settle for. Advocate for yourself and make sure that you get the best treatment. ERP.
Yeah. And I actually give people even less of a chance. So I always say, do you treat OCD? And if they say yes, I say, what treatment modalities do you use? And if on their own they don't say ERP, I say, thank you very much, and don't go to them, right? So Callie is 100% right. It's much more about their training and their background than it is about their license and qualifications. Caveat, they need to be licensed. There are so many folks out there doing work that are not licensed, and that should not be your primary clinician. So it is really important that you are not going to a coach or a life coach for OCD treatment. You need to be going to a qualified clinician who is licensed for many different reasons, right? Those of us that are licensed have the school, the education, the training, the proper background to be able to differentially diagnose, to be able to understand what might be going on, and to take steps that might need to be taken in certain situations. So they do need to be licensed, but don't worry as much about what the license is and focus much more on what their training and background is.
Well,
Patricia at 1211, ERP alone seems to not be bringing positive results for my son. Adding ACT and life skills have helped the anxiety. ERP brought too much anxiety, and he was exposed to a lot and was not able to do the response prevention. This is a great kind of comment that I'll just add on to as if it's a question, and Callie, you can do the same. But what I'll say is that this is wonderful that you were able to be flexible and creative around what your son's needs are, right? So this is the prime example I was talking about earlier, which is that some people aren't ready to start with ERP. We need to do some other work first. And often I'll even call this like readiness for ERP if somebody in fact has OCD. If we know that we're dealing with like general anxiety, actually ERP isn't the treatment model we should be using. It is much more of CBT skills, which might include other interventions, right? Maybe ACT, life skills, whatever it could be. And so it's important to think about, what are we treating? If we're treating OCD, we know ERP can bring some of the best results, but patients need to be ready for it. Many clinicians are integrating ACT and life skills into ERP, and we should be. And what's important to note is that I think a standard old school approach to ERP actually isn't useful for a lot of people. And that could also be what it sounds like we're talking about sometimes, right? Which is that we just go in and all we're doing is like hardcore exposures and response prevention. But when you're talking about life skills, that actually is ERP. If someone is going out and doing things that are important, showering, loading the dishwasher, going to work, going to a coffee shop and grabbing coffee with friends, if that's an exposure brings in anxiety, that is ERP if we're doing it with response prevention. And that's actually the best ERP because it's values based, and it's based on things that and skills we need and that are important and valuable to us. Callie, anything to add?
I think that was very well said. I don't have anything.
Okay. Grace at 1211. As someone who has OCD, I find it hard to differentiate between mental compulsions and cognitive distortions. I know what differentiates the two on paper, a definition of each, but I often don't know how to approach mental things sometimes because I don't even know what category, mental compulsions versus cognitive distortions, I might be experiencing. Any thoughts on this, Callie? And I can take it.
Yeah, I think that it can be kind of tricky, right? But if we know that it's a mental compulsion if we are trying to solve, going back to that solving point or that cycle of, okay, I'm stuck here, or I can't decide if it's this or this. Whereas a cognitive distortion is just kind of like a thought about something negative. So I always say when our anxiety is up here, it's a lot harder for us to make rational decisions. So if you're feeling anxious and you're having these thoughts that are just kind of overwhelming you about who you are as a person, or like labels, right? Like labeling yourself, labeling someone else, that's more of a distorted thought. Whereas a mental compulsion is I'm trying to figure this out so that I can make my anxiety come down immediately. And you can add to that, Liz.
Yeah, 100%, right? I think that what's really important here is I actually wouldn't get too stuck in trying to solve, is this a cognitive distortion or is this a compulsion? Yeah. If it's urgent, if it feels urgent that like I have to solve it, I have to figure it out, the goal is that we actually don't solve it and we don't try to figure it out. When you think about cognitive distortion, we're often going to use like relabeling, but cognitive distortions and relabeling them are often in a CBT model for anxiety. If this is related to your OCD, I would rather you treat it as a compulsion than a cognitive distortion. So if you know it's an OCD thought at the root, or your clinician has helped identify this as OCD, I would treat it more as a compulsion. I would not try to, because again, we wouldn't want you relabeling and trying to rename it, because that can become a ritual and can become reassurance for OCD.
Can I add one more thing to that too?
Absolutely, please.
Yeah, there's, I've seen a lot of perfectionism lately around treatment and doing treatment correctly. And I think that could come into play with needing to do treatment perfectly. Like, I need to label this correctly. Is this a cognitive distortion, or is this more of like an OCD compulsion? And so just to add to that, that in itself is considered a compulsion, right? If you're just trying to solve it and getting stuck in that.
Absolutely. Next piece, Mike, you've had a few questions and I'll kind of answer them at once. But one of the questions that you ended on, which I think is great, and Jory, I'm sorry you're dealing with picking. And what I'll say is I definitely want you to look for some webinars on picking. And there are some specific resources for BFRBs that we're probably not going to be able to get into today. But the treatment can look a little bit different for body-focused repetitive behaviors like skin picking than for OCD specifically. And so we want you to use that specific intervention. Which is often, there's a couple different ones that you can use, but a lot of folks will use comb or habit reversal as some of the evidence-based interventions for BFRBs. So Mike, one of the things you put at the end that I really want to talk about, this is really important, is you said that you have a good question, because during COVID times when people had germ OCD COVID, you did have to wash. And so how was it different? This is so awesome. I love that you asked this question because I want us to dive into it. And here's what I want to say. You're right. And there are times in our life where I actually want people doing rituals. I want people to do behaviors that look like rituals. So an example is, Callie, I think both you and I can agree, maybe I agree every day, maybe you don't, and that's okay. But there's nothing wrong with people showering every day, right? We can agree to that. And some people maybe shower every other day, but we can all agree that like the goal of OCD treatment, even if you are doing a million shower rituals, the goal is not that you never shower again. That's not realistic. That's actually not warranted and recommended from a hygiene standpoint. Just like somebody with contamination OCD, the goal is not that you never wash your hands again. If you're cooking raw chicken, I want you to wash your hands. If your kid has the flu, like probably a good idea to wash your hands in between giving them medicine and going to be with your other kid or whatever makes sense. So there are times where hand washes are recommended and they are important and they are needed. But the difference is when OCD comes in and when we're washing for OCD, it's no longer a hand wash that's recommended, that's for hygiene and that's purposeful. It's something that we're doing to follow the rules that OCD is giving us in our life. So an example of this is, there's a lot of examples of it. So let's just use the COVID one, because that's the one you brought up, Mike. But, for COVID, the CDC might recommend a 30-second hand wash. OCD is not going to be appeased with a 30-second hand wash and with potential cross-contamination, right? OCD is going to want a 30-second hand wash, and I clean my car keys and I clean my phone and I clean everything else that I might have come into contact with, and that I have this sterile environment. And if I accidentally retouch something that I touched before I washed my hands, now I need to rewash my hands and wash that item. This is OCD compared to I get home, I do a 30-second hand wash, and I accept that like I did the best I can. I talk a lot about this with some people will say, well, Liz, how do I know if I'm washing my hands before I eat for OCD compared to like it's just something my family has always done? And I'll say, okay, well, tell me about the hand wash. Like, what is the function of it? Are you washing your hands just because it's what you think you should do and it's what makes sense and it's what you've always done in your family system? Or are you washing your hands because you have to know that you don't cross-contaminate? An example of that is that someone who washes their hands before they eat without OCD probably does wash their hands. And after they wash their hands, they're willing to grab their cell phone. They're willing to sit down at the table. They're willing to eat food. If their pen drops on the floor, they're willing to pick it up and still keep eating, and they don't feel dirty or contaminated. Compared to someone with OCD washing their hands to try to keep their hands and body safe before they eat, they're not going to touch their phone during their meal. They're not going to pick something up off the floor. They're not going to cross-contaminate. There's going to be all these rules around the hand wash before, during, and after, right? They're not going to even touch the sink to turn it off. They'll use a barrier. And so we can see where you're right. Like in life, we can't eliminate rituals. I wouldn't tell someone with checking behaviors to never lock their door. Like you still should lock your door. It's a safe practice. But locking your door once serves a function that's healthy. Checking your lock 10 times serves OCD, which isn't healthy. Callie, I think you were going to add.
Yeah, I was just going to say, I think in those moments too, it's really good to do some positive self-reflection. Like the example I always use is, well, if someone has contamination OCD and we are on one of our final exposures, and that exposure is to sit on the floor and eat a piece of candy, initially you might say, I'll never do that. That's like terrible. Nobody would want to do that. And the reality is you're right. Like I don't really prefer to eat my candy off of the floor, right? If I'm not struggling with OCD. But the difference with that self-reflection piece is, okay, I just kind of feel like that's a little bit gross. Whereas someone with OCD has these extreme anxious fears of I'm going to die or something terrible.
Dangerous.
Right. It's dangerous. If I eat this piece of candy. So we want to get you back in the driver's seat of knowing I could eat the piece of candy off the floor. Does that mean I have to do that every day for the rest of my life? No, of course not. But we want you to be able to without feeling that extreme danger, anxiety type of feeling.
That's right. That's exactly right. Betsy at 1222. I've had OCD for years and have been and am doing ERP therapy. I'm still struggling with mental compulsions and pre-compulsions. What's an effective way to treat mental compulsions? I love this question. And I want to just kind of say for a second is that one of the things we hear a lot in the field is, that we have to address rumination. And I've heard people address rumination by saying, just don't ruminate. It infuriates me. Let's just be honest. Like y'all know I don't sugarcoat stuff here, even on the live streams. If we could just not ruminate, we would. There's no one with OCD that enjoys their rituals or enjoys mental or outward compulsions, right? We would do anything to not do them. We do them because we feel like we have to. And so the thought process of, well, just don't ruminate, that doesn't work. We need to understand what we can do to not ruminate. And then eventually I also want us thinking about what should we be doing so we don't even have the urge to ruminate, because that's the goal of treatment. The goal of treatment is not that you spend your life trying to combat the urge to ruminate and that all day long we have to just like not ruminate. That's white knuckling, because that means we haven't gotten to the root and done ERP for why we have the urge to ruminate. The goal is that, yes, we don't ruminate. That's our response prevention, just like you choose not to hand wash when you do an exposure. But eventually, I want that doorknob to not even trigger the urge to hand wash, right? I want thoughts to not trigger the urge to ruminate, and that's what's really critical. So, Callie, can you talk a little bit about that, about how do people choose to not ruminate, but then also how do we start to eventually lessen that urge and the pull to ruminate to begin with?
Yeah, I think that we have talked about this kind of a lot today within regards to values, but we choose to not ruminate by living in our values despite that thought being there, right? Liz has said that quite a few times today of that is an exposure of letting that thought circle and be there and still choosing to drop your kid off at school, even though that thought is there. And then something that I've found helpful with my own provider is if I'm so stuck in that rumination, like I'm driving the kid to school and I'm still just kind of thinking about it over and over and over. Sometimes the helpful reset for the moment can be doing something like counting back from 100 by sevens, or like focusing on your five senses, right? What you touch, smell, see, taste, and hear. But then giving yourself that opportunity to say, okay, and now I've got to move forward and continue on with my day. Because what we were saying earlier is if we're trying to solve that mental compulsion, it is only going to stick around longer, versus let's just let it be there. Let's let it sit in the background. And every once in a while, it's going to pop its head up and we're just going to continue to move forward today.
That's right. So what that means is that, as Callie was saying, some of these strategies Callie gave, we might call like rumination disruption, right? So it can kind of disrupt the rumination. What I want us to hear, though, as Callie's mentioning, is that rumination disruption can be really helpful when the urge is so strong and we need some tools to like not pull us in. Rumination disruption is not the treatment for OCD. So what I mean by that is I don't want us to be doing serial sevens where we subtract backwards by 7 for every day, all day long, just because that's our only way that we can not ruminate. I want you to be able to be present and enjoy life, enjoy work, and enjoy conversations and these different things that are important. And the only way we do that is we have to target the core fear that's causing us to ruminate. So what that means is that we actually want you to not try to suppress rumination by saying, oh, I can't think about this, I can't ruminate. We need you to allow the thought, which means we allow discomfort, we allow anxiety, we allow that thought or trigger to be there. That's the exposure. And we choose that I'm not going to ruminate. I'm not going to try to solve it. I'm not going to try to do anything about it because it's going to get me more stuck, and I'm going to move forward with my life. The more we actively do this and we allow that uncertainty, that core fear to kind of come to surface and to not try to fix it or get rid of it, we will have freedom and the urge to ruminate will be less. The goal eventually, you guys, is that thoughts that we have stay thoughts and that they don't become triggers. If we are responding, our thoughts will continue to be triggers or our thoughts will become triggers, and that's when we get pulled in. So it's really important to recognize that I can't always change every thought you have, but wouldn't it be awesome if it was just a thought that didn't mean anything to us and we didn't care about it compared to it's a trigger because it sticks. So I know we're running out of time, so we will get to a couple more questions that we have, and hopefully we will. So Marion at 1228, how do you switch off from the thought though, because it can be so excruciating? I had an issue last night and went in round circles until I was exhausted. Thank you for joining from Liverpool.
Yeah, I think that's something we kind of hit on just now too, which is there is a time and place to, if you can't break yourself from that, to kind of do that grounding exercise like the serial sevens, but not living in that the whole time. And one of my favorite things to set for myself is, if I'm really stuck in rumination route, is to give myself a goal to laugh. Give myself a goal to laugh at some point in the next hour or so, because then that is reminding me throughout, okay, I got to find a joke, or I got to find somebody to help me check in and be present. And so if you're giving yourself a goal like that, you're focusing more on the outside experience and your values, despite the thought being there. And really remembering too, we're not suppressing it, right? Like the thoughts, just like Liz said, the thought's going to come up. We're not swatting it away, but we're still focusing on, with that thought there, okay, I need to laugh. So that's just one more thing I would add.
100%. We have a couple of final questions. I want to get to all of them because it'll drive me crazy if I don't. So Callie at 12:39 your time, Skyla. Callie, here's what I'll say. It can be really hard to differentiate what's OCD, what's GAD, and how do I approach which one. But what I'll say is, I want you to think about, am I responding to anxiety? Right. And so overall, whether we use ERP, whether we use exposure therapy, whether we're using CBT, I want us to really be thinking about, am I responding to my fear? Am I making my fear bigger by the behaviors that I'm engaging in or not? And across the board, that's the goal of treatment, right? The goal of treatment is that thoughts are thoughts, they're not triggers. And so whether it's for GAD or whether it's for OCD, we want to approach it that way. Next question, Marcia, how are comorbidities diagnosed as a parent? And this should be done with a qualified clinician. So those of us that treat OCD, we should also be continuing to assess and understand the whole picture of what might be going on. Sometimes what this means is that we'll refer patients out for something like neuropsych testing to really get a better understanding and have a full battery of measurements completed if we think there might be additional comorbidities that we don't specialize in diagnosing or treating. But really, you should be working with your licensed clinician to help determine if there could be some other stuff going on and if they can help understand and sort that out, or if you should do something more intensive like neuropsych testing. John, we would want you to see a psychologist out of the 3 options you posed. So family doctors are not going to be specialists in OCD, right? Remember, pediatricians, doctors, they don't have their training and background in mental health. We want you to see someone who has training and background in mental health. And psychiatrists and psychologists both do and can be great. A psychiatrist is often going to be someone who might help provide an OCD diagnosis. They also will be the person who should be prescribing and helping you with medication management, but they're often not going to be the ones doing behavioral interventions and helping you do ERP and understand what that looks like. That's going to be a psychologist, a social worker, but a licensed clinician, right? Depending on your state and what the license might be. Connor, this is a great question, and it is, one of the most common OCD fears. So Connor said, is it possible for something to bug you forever? Some of my obsessions last so long, and one of my main fears is, what if this bugs me forever and I can never stop thinking about it? Here's what I'll say. This is actually at the core of most and a lot of people's OCD, right? The fear is that, well, if I don't solve this, then I'm not going to feel better. So I'm not going to be able to move on, or I'm not going to have a good experience, or it's going to impact my life in the future for different reasons and in different ways. And what I will say is we can absolutely address this, but we 100% address it without ritualizing. Because what I want you to remember is that every time you ritualize because of the fear that it's going to last forever, actually perpetuates the chance that it's going to last forever, because we're keeping that alive. And so what we really want to lean into here is like, I have no idea how long this may or may not bug me, but I'm going to choose not to solve it and live my life anyways. And when we actually succumb to that potential, right? We're willing to take that risk and lean into that uncertainty there, you will have freedom, and that will allow it to not bug you and for you to actually stop thinking about it. But if we keep focusing on trying to make sure we don't think about it forever, that is a much stronger likelihood and chance that we're going to keep thinking about it forever. Absolutely. I love Kim Quinlan's podcast, Your Anxiety Toolkit. She also has wonderful resources. So Kim is an incredible IOCDF advocate and clinician, and I absolutely recommend checking out her stuff. Have either of you experienced sexual orientation OCD, and can you touch on it a little bit? I'd love to hear your perspective from a female. Callie, I'll let you take this one.
Definitely. I had an experience in college, actually, when I was planning to move in with my best friend, and we were going to be roommates for the first time. She had to stay on campus longer because she was a basketball player, and as a distance runner, I was able to go off. So we had waited for this moment. And then sure enough, month before we were about to move in and be roommates, I started struggling with sexual orientation OCD. And I think when I had the best advice at the time, when I was kind of debating, and at this time I had just gotten my OCD diagnosis. And so I asked someone, should I not move in with her if I'm struggling with this and trying to figure out what in the world is going on? And the advice was, you were going to move in with your best friend because that's a value of yours. So why would you not move in with your best friend? And so I did. And if I wouldn't have, I guarantee I would have struggled with that subtype much, much longer. And so sure, at first it was hard, and there were some exposures I had to do around that and uncertainties that I had to lean into. But eventually my OCD moved forward. I moved forward, and there was freedom in that. And kind of to reflect on this pattern of what we've been discussing, when you aren't trying to solve, you actually get that clarity later, right? Yeah. So I was able to move forward without knowing. And then later I looked back and I was like, oh my gosh, that was all my OCD.
Right. That's right. And that's the piece I want us to remember, because I think a lot of times people are afraid to say that, and people think, oh, I'm going to have to be totally uncertain forever. And that's not what it's about. Yes, we have to be uncertain in the moment of treatment, right? Because that's the only way we can move forward and past our trigger. And it feels really big. But actually, when you accept it, you get more certainty, you get more clarity, because you're able to see that that was OCD in different ways. So what I will say, Chloe, is we've done a couple webinars specifically on sexual orientation OCD. It's a very common subtype for both men and women, for individuals of all sexual orientations as well, right? It doesn't impact just one or the other. But what we know across the board is we treat it just like other types of OCD, right? That if we are trying to solve and be certain and know for sure, we will get stuck. So the message of today is hopefully that ERP works, that ERP is an incredible treatment option. Of course, sometimes that we need to think about other treatment interventions and ways we might use those when we're treating OCD or we're treating whatever we're dealing with. But what I hope you heard across the board from both Callie and myself is that our goal is that you live by your values, not by OCD. Don't ever let OCD convince you that you have to accept living a half life because you have this diagnosis. You can live a life with freedom, and you can live a life where you're present. But you can't do it if you're still giving in to ritualizing and compulsing and trying to solve and understand. And so what we have to do is we have to choose freedom, which means being uncomfortable right now and giving up OCD's control of solving and understanding to be able to live that life we want and that life that you guys all deserve. Thank y'all for joining. I hope you remember help and hope are always possible. Callie, I'll let you wrap it up.
Yeah, thanks everyone. This was really encouraging for me to hear that you guys all got such great feedback. And I can't wait to pop on again next time to hear how it's helping you move forward and obtain the life that you want to live.
Which is next week, right, Callie?
That's right. Next week.
Awesome. So Callie will be joining me again next week for our live stream. So same time, same place, next Wednesday at noon Eastern time. We are so excited. We'll pick up where we left off. We have more pre-submitted questions, but of course you guys can come back and ask a lot more. We're so happy to hear that these live streams are helpful and are so grateful for IOCDF for allowing us to do this and hopefully impact you guys in a positive way. Thanks, you guys.